Hi, everyone. Thank you for joining Global Grand Rounds this morning. I'm going to be the facilitator for today. My name is Katie Ford. I'm going to go ahead and hand it over to one of our medical directors, Dr. Vaidya.
Thank you, Katie, and welcome all to today's edition of Global Grand Rounds, which is the medical education arm of Global Offsite Care, who most of you are familiar with as a nonprofit supporting global telemedicine across the globe. I'm one of the co-medical directors along with Dr. Katsouras, Michael Katsouras, and I'm so happy to be able to welcome Dr. Pradeep Vaidya today. He is the president of Hospice Nepal, professor of Department of Surgery at TU Teaching Hospital in Kathmandu, Nepal. He's also the assistant dean of the institute there, and he's also a specialist in hepatobiliary and pancreatic surgery. He is well known to Global Offsite Care as a representing as a partner of TU Teaching Hospital through the Rotary International, and in fact has come out to the U.S. and just prior to the pandemic to get to know Global Offsite Care and vice versa. There's been a site visit and dialogue in the past at the facility in Kathmandu. Welcome, Pradeep, calling you by your first name.
Yeah, thank you.
Your invitation. So looking forward to your talk. Thank you for coming.
Thank you very much, Dr. Pichia. Kathy, thank you very much for all the support you've given. And Dr. Good, a shout out for Dr. Good. Hello. I will just share the screen. Can you see my screen?
Yes, we can.
Just have to go quick, fast one, yeah. Okay. As mentioned, I'm Pradeep Vaidya. I'm a surgeon. Why do I go to palliative care? Because I do a lot of cancer surgeries and I see a lot of difficulty patients. I find palliative care very interesting. It's a lost art that doctors, medical people should know, which is very important for us. There is no conflict of interest. All photographs of the patients are taken with consent, and we have mentioned strictly that it's for training and awareness training, and they've all agreed. I'd like to start with a small story. Palliative care is like that. It's from emotion, it's from heart. So it's a short story of this patient. She is a mother of a colleague of mine, a doctor in my hospital. As you can see, her face is cachectic. She's lung cancer patient, had been for on treatment for nearly 8-9 months. When she was brought to hospital, the doctor called me because I was a palliative care worker to ask if I can do anything to her. And I talked to her and she was pretty fine. She was very weak. It looked like she would not pass the 24 hours. She was that weak, but she was conscious. She was not in pain, and she was slightly dyspneic because of lung cancer probably. And she was telling me, send me home. I want to die in my home. I don't want to die in this hospital. And she knew she was going to die, but she didn't want to die in hospital. So I counseled her as far as possible. Then I went to the son and told him, see, it's her wish that she wants to die at home. Why did you bring her here? It seems that because the son is a doctor, the moral blackmailing for him to bring his mother to the hospital was so much from the families. The social pressure was so much that he had to bring her to the hospital. And he said, I know I could have kept her there, but my families were so against it that I had to bring her. Then I said, okay, because you've already brought her here, why don't you take a single room, get your family together and bid farewell and stay with the patient. He said, that's fine. And he said, okay. I went to perform my operation. Then when I came back from my operation and went to see in the ICU to see my patient, I see this lady in the bed with ventilator on, cannula in the nasal cannula, and then a catheter and cannulas in the arms, and tied to the bed. I said, what are you doing? Why is she tied? She said, she was fighting the intubation tube and she's trying to remove it. So that's why they had to tie her hands out there. I just couldn't believe it. I realized that ICU pays, I mean, however good you may be, whatever specialty you may be, even in ICU, the people should know that palliative care is what palliative care is, and people should be given a good death. If you remember your heydays, there are 4 cardinal ethical issues. One is independence. The other is justice, beneficence, and maleficence. Now, for this patient, her wishes, her living will was to die in her home. We neglected that. We pushed her in. And in fact, we pushed a lot of tubes in her mouth and everywhere, caused her more hassles, problems. So where is the benefit? She's not going to benefit in any sense by this ventilator because she's going to die in a few hours anyway. The maleficence do no harm. We are causing more harm by putting tubes in her. Psychologically, she's in very distress and nobody cares. And as for justice, while she was holding this bed and ventilator, I had 2 patients who had a motorcycle, young patients who had motorcycle accident. One of them required immediately abdominal surgery for bleeding, but because of no ventilator and a bed, we had to refer the patient to other hospital, and probably in the way she might have died. So where is the justice? So ethically, it was so wrong. But the doctors, I asked them, why did you put her in a ventilator? It seems his very good friend is a critical care expert in ICU. And while they were transferring this patient to the ward, she had little dyspnea. So they did a blood gas. I mean, this lady was going to die in a few hours. Everybody could see it. They did a blood gas. They found abnormal blood gas. So they put her in a ventilator and all the tubes inside. So I think we really need to know why the specialties do not think of human touch and humanity while we are working on being a specialist in disease-oriented. So WHO defines palliative care as an approach that improves the quality of life of patients and their families, remember the families also, facing the problems associated with life-threatening illness through the prevention and relief of sufferings by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Now, some people may ask, what is life-threatening? Life-threatening is like cancer, kidney failure, heart failure, lung failures, rheumatic arthritis, any chronic diseases that causes lessening of life. And what is the difference between hospice and palliative care? Where palliative care is, as mentioned out here, it's an impeccable assessment, early identification, and treatment. Whereas hospice is understood as a place where a patient is sent when it's the last terminally ill. There's nothing you can do for her comfort. We send him to hospice around when she has not more than 6 months to live. So that's the difference. Otherwise, the support given is same. The diseases that require palliative care is like, as I mentioned, cardiovascular disease, respiratory disease, AIDS, diabetes, multiple sclerosis, rheumatoid arthritis, neurologic disease, Alzheimer's, and even cancers. Now, why do we need palliative care? Each year, an estimated 40 million people are in need of palliative care in the world. This is WHO data. 78% of them live in low and middle income countries like ours. Worldwide, only 14% of people who need palliative care currently receive it. That means most of them in developed countries. So probably 4% of people, population in the world, in the low and middle income countries get palliative care. And you saw, not giving a palliative care to the patient can cause so much suffering to the patient and probably the family also. Now, this is an interesting slide because I find it, as I become a doctor, a more specialized total hepatobiliary pancreatic surgeon. And I have, as mentioned previously, I had a lot of 3 tiers of residents who learned from me. I have to teach them. I've focused my knowledge into a disease. I've objectified a human being into a disease. I last about 2 weeks back, I was standing waiting for my residents and for rounds, and I saw a very senior consultant doing rounds with as many 20 residents around him. And he was talking about gastric cancer. The patient had gastric cancer, obviously. So he mentioned everything about investigation, treatment, everything. But, and after all that discussion, he just walked away while the patient who was lying in the bed was trying to contact him. The juniors told him, wait, I'll come back later and talk to you. And I was so shocked that a senior doctor consultant will not even talk to a patient, but to treat the disease, but not know who the person is. That is what physical support is now, curing a patient. What happened to the medical system where we care the patient, emotional, psychological support, social support, spiritual support, and support to the patient's family. If my generation people probably know of family doctors who come to home and they take care of patients, their families, their children, they know everything about the history. And when the children do not do well in the schools, the parents complain to the doctor, and the doctor says, if you don't do it, I'll give you an injection, and we are scared for 6 months trying to learn that without getting injected. So these are the social things that we had. Nowadays, people are more important, more specialized, so specialized that we talk about disease, we treat disease, we not treat the patient. I don't know what happened. Okay. Previously, palliative care was thought to be when the disease is diagnosed early, you don't need a palliative care, but as disease progresses, then you need palliative care. And vet and bereavement is also part of palliative care. And usually in the beginning, curing is more important by treatment of the disease. My feeling is the cure, life-prolonging intent and the palliative care should go together. I have seen my colleagues who were diagnosed as diabetes, were completely healthy before, completely destroyed by emotional panic because you need to have insulin forever, you have diabetes, your life has collapsed, changed. So they needed psychological support, emotional support, which could have been helping them. But now I think that is why we need to have life-prolonging intent and palliative care together, as shown in the slide. Now, WHO also mentions that cancers can be cured. 1/3 of the cancers can be cured. 1/3 can be stopped for some time. 1/3 is too late, they come late. But if you know in low income and middle income countries, more than 2/3 of the cancer patients come very late because of the lack of facilities, lack of diagnostic properties, and so on and so forth. That is why in our countries, the cancer patients are large numbers who are not being able to be cured, but we need palliative care for them. So what we're doing is 1/3 will be cured, that's well and good. The rest will require palliative care because ultimately those who are stopped will again progress to a terminal disease and require palliative care. So in Nepal, palliative care is so rudimentary that there are so many hospitals in Kathmandu or in other cities that can take care of gastric cancer, rheumatic cancer, or any cancers that you think of. But how many beds do we have palliative care? We have less than 100 beds. In fact, one palliative care just stopped working. So we have less than 50 beds probably in a palliative care. Now, people ask, where should palliative care be given? I'll come to who should be given later, but where should be given? Is it a hospital care, home care, or independent community hospice? I think each has their own mind. Most in West probably think a hospital care is better. And most in my countries also, we do not tend to tell the patients that they have cancers. We tell them that there is a large ulcer in the stomach, which will get cured. So they expect to be cured, so they want to be in the hospital. So because of these reasons, hospital is quite popular. Home is obviously, people may think that home is a good place for palliative care, which I think should be accordingly. But sometimes you need an independent community hospice. Now, hospital care is well and good, but see, the hospital have their own rules and regulations. They have to come on time. You can't bring people out there. There's no space to sit down comfortably, and there are a lot of other patients. So hospital may, when there are most of the cancer patients come late stage of disease, and you have a limited number of beds, if you put all these cancer patients in the hospital beds, I would not have beds for operating patients. So that's a big problem. It's not profitable enough because all the money they had are spent on curative like chemotherapy, radiation, surgery, going to other places, then coming back. When they have lost all their money and they have lost their will to live also, they come to a hospital where there's not profitable enough. So hospital don't want to take them. There's no trained manpower. We just have one fellow of palliative care in my country. We are all trained in different levels. We cannot provide home-like atmosphere for a patient who's dying out there, and the nursing medical staffs are already overburdened by the hospital itself. Having cancer patients, they will not be able to give that service. Now, home care, not everybody has a fantastic home, good home. This patient had a lymph node carcinoma with a large gaping wound in the neck. It was infected, fungating, and he was in severe pain. We brought him to hospice, gave him morphine, treated the wound, got it better, and he used to carry a calculator in his pocket. So we asked him, why are you carrying a calculator always with you? He says, I know I'm gonna die, but I have a small business in carpentry, Nexus deals. So I want to go back as soon as I'm healed here. See, even a person who's dying, he knows he's going to die. He has to finish all his dealing because he wants to take care of his family. His family is a very, very poor family. They live in a one big room, 5, 6 people, but he still wants to go home. So not everybody has a very good room, but for him, home is still a home house. Now, problem at home is you don't have appropriate space. As I mentioned, it's very difficult to start IVs if you require. And one other problem is like cancer, like AIDS, people think of cancer as a disease that you should not be mentioning. So people do not like to tell people that I have cancer relative in my house. So they do not tell them. So it's isolation out there. They work whole day, then come back to a cancer patient who's complaining of pain, not being treated properly, organized food, hospitalization, all these problems. So obviously the family, not the patient, the family itself goes into depressions. Now you've already heard of backseat drivers. The backseat drivers are people who are super experts who sit in the back and give advices to the front drivers on how to drive. We have similar things in my cancer patients. In my Institute of Hospice Nepal, we have a 8-bedded institute. People from far away comes to Kathmandu for a visit, and they realize their relative is in hospice, so they come to visit him. And when they visit him, they say, "Oh, I have a similar. I have a person who has a similar disease who went abroad or got operated there, and he became all right." Now, this may be true, not true, doesn't matter. But for the patient or the family of the patient who cannot afford to go abroad, cannot spend that much money, will feel guilty that I could not take my father abroad. If he didn't know, he would have not bothered. But now people have told him that he might get cured. Now people like to believe whatever doctor says, that this patient, if he tells him similar disease, will definitely get cured. So obviously he will feel guilty. The son will always feel guilty that he could not afford to take his father to the good place. The father may feel guilty that my son, I've got him this age, and he cannot treat me properly. So these backseat drivers are the most dangerous people I've seen around. And it's costly sometimes because the patient has to be taken to hospitals, sometimes to other places, doctors, nurses, and it takes a lot of money traveling. About the institute, I'll come to that. A case study of developing palliative care in Nepal. As I mentioned, we were 3 surgeons and 1 business person, 4 of us. We were pretty young, starting our career. We wanted to do something in the society. I was in Japan for my PhD, so I realized there was hospice, We are not sure what hospice and palliative care was really completely, but we started, and in internet we tried to find out what hospice palliative care was, and we humbly started with 4 beds in a local nursing home. We raised with government. We supported completely free of free charges, free service for nursing, bed care, and even morphine was available then. We used to give morphine. This was in year 2000, 21 years ago. And we built this small institute. We told this designed by a very good architect. We told him it should be cheap to build, and it should be maintenance free, because we run it into donations, and we need to make sure that it doesn't cost too much. While we have seen some social organizations where your offices are grandeur and the patients live in a shed because you have a vehicle, you have a good office, but the patients are not in the proper management. So we wanted to make sure that the hospice building is not very costly, but inside it should be comfortable. So inside, the architect design is so well that it's bright. This is the corridor and this is the rooms. Now, this is the first time when we did that the patient families could sleep in a bed, because otherwise in hospitals out here in Kathmandu, patient families used to have to sleep in the floor because there's no bed available for them. So what we did was we built a small bed which could be used as a storage, and there's a Dunlop, they can sleep out there, and there's a good breeze and good lights and nursing part. And this is the patient who's lying there. The families can come anytime, visit him, visit her, eat together, sit down, pull a chair, bed, relax comfortably. Anytime, they can come in anytime, join, go back, really comfortable. And the nurses take care of them 24 hours a day. This is a single bed. We have a bathroom attached for people who can pay and want to stay a little bit, but it's still a very subsidized amount of money. I just wanted to show you what a simple, small things can make a difference in palliative care. We had a small shed. We thought, okay, somebody brought us cutlery as a donation. We didn't know what to do with it. So we said, okay, we'll make a small kitchenette so that people can cook themselves when they want to have snacks. So one night when I was coming from a party, I just dropped in my hospice, and they were all sitting down in the kitchen eating. So I was just talking to them. And these 4 ladies, you will not believe, mentioned our country is a patriarchal country where women have to do all the cooking and washing dishes. And these are the 6 patient families whose patients are indoor in the hospice inside. I was talking to the ladies. The ladies said, this is the first time in 7 months I got rested. Otherwise, I have to go work in the afternoon. I come back and cook. I wash dishes. I take care of my mother. 7 days, 24 hours a day, 7 months, I've been doing just that. Here, when I brought my patient to hospice, I have 6 people to help me out sometimes when I have to go for shopping or something. And especially in the evening, each takes turns in making food. Each takes turns in washing dishes. So for 5 days, I don't have to do anything, which is amazing. For ladies in Nepal, this is amazing. I'm so relaxed, and you get different tastes out there. So we never thought that it would go that far, but a small thing like this can make a lot of difference for families also. And that is the essence of palliative care, that we take care of the patient and the family also. Similarly, the whole building that I showed, although it looks cheap, was very costly. Somebody paid for it. It was completely free of cost. But I paid for this grass in money, cash, because in Nepal, in winter, people like to stay outside in the sun, in the grass, and eat peanuts and shell oranges and eat. And these are the cancer patients. Their family on holidays come around with their children. We have carom boards, cards, TVs. They can watch, relax, and makes a lot of difference for the family and the patients. Obviously, we have oxygen. We have oxygen concentrators, oxygen cylinders. We don't have oxygen plant. This is a cancer patient who's in oxygen 24 hours a day. And unfortunately, we're told by the patient family not to tell her that she's got a cancer. So every time I go visit her, she's like, When can I go home? When can I get cured? She thinks it's a wound in the lung which can be cured by us. She doesn't know it's a cancer that's causing her near death. So these are the problems that we face in palliative care. Pain management is one other thing that we need to know in our palliative care, especially not only in palliative care. I think in my surgical field, because of palliative care, all my patients, my surgical patients, do not face pain. My residents are so scared of me that they would not worry. When they see anybody with level 3 pain score, they go and give injections immediately. So my patients, at least hopefully, are pain-free. This patient is a cervical cancer patient. She was brought to us by a relative of her. They said for 2.5 months, she's have been lying in bed because of severe pain. A lot of doctor medications, they give cetamol, brufen, but nothing's worked. So when I went to interview her, she was so angry. I'm in so much pain and you come and disturb me, get out. So I just walked out, called my staff, told them to give a injection of morphine and give a tablet morphine. 2 days later, when I go to see her, she's sitting out there relaxed. She had just visited a temple. She's come back. A morphine tablet costs less than 2 cents, US cents, 2 cents. 4 of these tablets would cause her the comfort that she can live properly whatever time she has. She doesn't have to suffer. It's so cheap. It's just the lack of attitude that people are suffering in my country, in my hometown, because people do not know there is a palliative care or a hospice. Forget the people, even the medical doctors, medical personnel do not know what hospice is. This again, pain management. One time we had lack of morphine. We used fentanyl dermal patches. I don't know, for some reason, Asians, because of hair or something, it's very difficult to attach them. It keeps on falling, so we had to tape them. We use syringe divers, which is very costly, 70,000-80,000 per piece. But this patient is a cervical cancer patient. She was in severe pain, had 3 children. We gave her continuous morphine, Perinorm, and Buscopan. She's comfortable. She carries it in the bag. She goes around with the children. Her life was completely changed. She died in 3 months' time, but she really enjoyed her life with the children when she had no pain. Now, we take care of family also, as I mentioned. This family is a grandfather, son, and grandchildren. Only one lady was in the house, the daughter-in-law. She was going outside her home for a training for 2 weeks. She called us and said her father-in-law had pancreatic cancer. He's in a catheter, but he doesn't have any problem at all medically. But because nobody's there to take care of him, can I bring him to hospice? I said, fine. So 2 weeks he stayed there. His grandchildren would stay there sometimes. The son would go for work. 2 weeks later, she came and she just took the patient away. So hospice is 24 hours open. Anytime any patient who feels like can come in, get supported and go back whenever they feel like. This is the patient that I was talking about. We do community support also. This is a staff who's giving injections. He's cleaning the wound. And sometimes when he has problem, he calls me and we go for community service wherever it is, usually in Kathmandu Valley. And when we go to community service, the patients are usually lying down, they are sick, they don't need extra care. We examine, but basically they are quite comfortable. But it's the patient family that needs 1 and 1.5 hours of counseling because they're worried, what happens if he bleeds? What happens if he dies? What happens, how do you know he's dying? What happens if what can he eat? When can he bathe? There's so many questions they have. They're not used to cancers or chronic diseases that it needs counseling for them. And this is the perfect view from a patient. This patient that I went to, his house is in a hilltop, and you can see the whole mountains, beautiful valley, and the temples out there. Why would anybody want to come to a hospital and die there with all these tubes inside, when you can comfortably die like from heaven to heaven? But that is in the urban area. Look at the rural areas. This is 70% of my country is like mountainous or hillious. And to reach a medical facility takes 4 days of walking. Fortunately, nowadays we have a lot of internets and data cards so people can communicate. And for example, this is a Kathmandu Valley. The airport is here. My hospital is somewhere here across the valley, and my house is somewhere in the middle. And this is where my hospice Nepal is. Usually, previously, when there was less traffic, I used to travel in 10 to 15 minutes, I used to reach here. Nowadays, with traffic, it takes 2 hours to reach here. So going 2 hours, coming back 2 hours, 1 hour, probably 1 to 2 hours seeing the patient, my hospital would kick me out of my work anyway. So what I needed was a telemedicine system. So in rural areas and places, even in my own city, when my staffs change over, I do trainings from internet. I sit at my table and take classes. This is a nurse. I can see I using Skype, and then the patient, the slides, and just talk to them and explain to them. Obviously, I visit them, but very rarely nowadays because the other colleague who was doing fellow had to go to Ireland for fellowship. So I was alone out there taking care of hospice. I could not reach there every day. So I used to take over. I used to see the patient by telemedicine. My staff used to go to community service with a laptop, and he's got a vehicle and a laptop. He goes. If there's any problem that he can't handle, he opened the laptop. Most of the houses have internet. We connect, and I talk to the patient or patient family and take care of the patients. This is again a Patna hospital, a hospital in the city has taken a pilot study where they have taken about 25 villages. They put one health assistant in a motorcycle, and he goes around looking for cancer patients. He notes down the cancer patients and any palliative problems. So any problem, he calls me at 6 o'clock in the morning. I just woke up in my bed. He calls me and says, okay, I have this patient, and I just take my tab, get up, take my tab and take care of the patient. And then as I finished giving medications, I didn't know at 6 o'clock what the nurses were doing, the junior nurses, training nurses. And they asked me, why are you giving this medicine? So it took me half an hour just to explain what was going on. So just in my bed itself, I had to take care of these people. So it's so easy sometimes that you can do things easily at that time. It's just a small tab. This is in hospice where a patient family wanted to talk to me. It would have taken 2 hours to reach there, 2 hours to display. I can hear 1.5 hours talk to her. You probably can't hear the voice. It's good because if we are talking Nepali, you would not understand anyway. This is an interesting case. This patient in the hospice had a skin disease, and I used all the ointments for 2 weeks. I've been trying to do it. It didn't work. So I went to my hospital. I called a professor of dermatology, asked him to come to my office for a cup of tea. So when he came, I requested, why don't you see a patient also? He said, I can't move anyway. I said, don't worry. I got a laptop, put a patient out there, talked to the patient. He talked, gave him medications. 3 days later, the disease had gone, completely healed. So a specialist, right from there, instead of taking him all the way to the hospice, treated the patient, and patient was comfortable. I'm happy. He's happy. He's got a cup of tea and no payment anyway. See, he is talking. He's a professor of dermatology in my hospital. Very senior person. And this is while driving also, you get a call. He said, and because it's a cancer patient, his health personnel will keep on saying, oh, this patient is in severe pain. What can I do? So somebody's driving. I'm not driving and talking, but I'm in the backseat. There's a small tab, Samsung tab. I talk to the patient and treat the patient. So what is the problem with, what is the challenges we face in palliative care? And who should be giving palliative care? Now I'll come to who again in the end. The challenges we face is lack of awareness among policymakers, help, and most importantly, I don't blame the people, the public. I blame the health professionals who do not care about palliative care, who ignore palliative care. And these are the people who knows these are the cancer women require some support and would not give it. So it's sometimes very frustrating when your medical personnel do not understand that palliative care is so important. There's cultural and social barriers here with religious beliefs that sometimes the dead should not be in the home, sometimes they should not be in the hospital. So there's so many conflicting things that you have to manage out there. But these are small things because when patient is diseased, we can treat them properly. A misconception about palliative care. People think when you talk about palliative care or hospice, oh, it's for cancer patients. My patient is not a cancer patient. So they never try to get this support. And mostly they think when you go to hospice, you're going there to die, like in a temple where you're going to die in the. So people do not want to, like you don't want to take your parents to the palliative care because you are sending him to die. So people have this misconception. And the most important misconception among medical personnel is we have morphine out here, but they don't use it because they're either worried about respiratory distress or they increase substance abuse. I tell them, this is a cancer patient. He's going to die in 3 months. You don't need to worry about addiction. The God will worry about addiction when he reaches heaven or hell. Why are you worried about? Give him some morphine, but they're still scared because of respiratory distress. We are trying to change it. Slowly, it's moving. More and more people are using morphine, but we need to do it more often. So the way forward is, how do we go forward? We need to create awareness, and we are trying our best. Policymakers, medical personnel, public. Even my next door neighbor would not know that there's a palliative care going on in Nepal, and he would be having his relative or his loved ones suffering with cancer and not telling us. So this is the public awareness that we really require. We would love to have integration of palliative care in national health system, but our health system is so overwhelmed with NCD, the local diarrhea, the pandemics, that they're not worried about palliative care. In fact, we are mentioning that in this pandemic, we need to worry about palliative care because a lot of patients did not get bed in ICU. There were a lot of patients who were suffering out there. They require palliative care, but nobody listens. Production of morphine in the country. We are very lucky that morphine was produced in my country itself. So we don't have, there's no lack of morphine. Unfortunately, it's very cheap. It's about 2 or 3 cents a tablet, 2-3 tablets a day, twice a day. And patients you can see the change in 3 days and just walking around living their life. And for awareness, we have 2-3 programs that we continue trainings. This is the handbook that we produce for Hospice Nepal. And this is a national health training. We had some help from England, hospice palliative care people, and we produced this book. Now, I started with a story. I'd like to, beginning of the end with a story. Why palliative care is so important. I saw one where you had a difficult death. This patient is a 33-year female who was sent to me as a jaundice, obstructive jaundice. That is, probably had a stone in the common bile duct. So they told me, I do ERCP also, surgery also. Do a ERCP, take the stone out and do the operation lapically. I said, fine, send her here. Then when I saw the ultrasound, it showed that she had cholangiocellular carcinoma, the cancer of the bile ducts. This is very bad news because cholangiocellular carcinoma is not very easy to treat. Although she looked young, so we tried operation. It was unresectable. We had to leave her, close it down. Then she's quite affordable. She went to abroad for chemotherapy, but had some very bad experience, came back. 1 month later, she called me and said, Pradeep, I just have 2 requests for you. One, let me not suffer with pain. I do not want my family to see me in pain. I can I can bear the pain, but I don't want my family to see me in pain. And the second, I don't want them to see me in dyspnea, like trying to gasp for breath when my children comes to meet me. So I said, I'll do my best with what we know, we'll do our best. And then 1 month later, she did have severe pain. I brought her to hospice, gave her morphine, 60 milligram long-acting morphine for twice a day. She became perfectly fine. She went home. Then about 3 months later, my staff used to visit her. And he called me up saying, Pradeep, Dr. Pradeep, this patient is like very serious. She's not in a very good condition, but she wants to meet you. I said, I can't do anything more. Do you really she does want to meet me? She said, yes. Now, when a dying person wants to meet you, you feel that it's an obligation, you want to go and help. So I said, I will do that. I'll go visit her, but 3 weeks, and I was so busy that I could not take time off to go. And one day, my staff called me and said, she's not going to last long. If you want to visit her, you have to go now. So on one of my Saturdays, a holiday for me, I took a time off, went there, and I asked her, see, what can I do for you? She said, no, I don't want you to do anything now. I just want to thank you. And I was so shocked. I said, why? She said, she gave me a little history of what her life was like. She said she married young because of love, and both her families were against it in the beginning. So they really had to suffer to survive. And they had 2 children. We are now grown up and stable, but till then they really had to suffer. 33 years of her life, she was struggling to make ends meet, get the children studied, help the parents. I mean, it was terrible. Both of them working so hard. And suddenly when cancer hit her, she was so shocked. She knew she was going to die. But she came out of it. She went through all these medications. Then she was worried about pain. Once the pain got relieved, her husband took 3 months off from office. Everybody knew that she had cancer. So she said that 3 months, I had so much life in me. I talked to my husband. We went for walks. I saw all the things that I wanted to do. I went to all the spiritual places that I needed to go. I did everything I wanted. Now I'm so happy that that 3 months, she compared to 33 years of her life and said, this 3 months has been a blessing while she was dying of cancer. And she said, because you were there. And I wrote stand by me because she said, she didn't interfere. She didn't call up a lot of time, but she said, just knowing that there's somebody to look after me. There's a hospice palliative care. Where can I go if there's a pain? I can call up a doctor and say, see, I am in pain, and somebody will come and look me up. Before that, she had nobody to talk to. You go to oncologist, they'll talk about chemotherapy. You go to a surgeon, they'll talk about surgery, but nobody there to look after me. So she said, thank you very much for what you have done. And she looked at her husband and said, I think my time has come, I should be leaving. And husband, although men are not supposed to cry, there was a tear in his eyes, and he looked at her and nodded his head. Can you imagine a person, a loved one, asking for leaving, dying, and saying that I give permission to die comfortably? I left them, and 1 week later, the husband calls me and said, my wife died very comfortably. Thank you very much. The family was nearby, everybody holding hands. They went through that spiritual things that they're supposed to do, and she passed away happily. And although she had cancer, she didn't suffer much, and he thanked the hospice. So the first story was about how death can be so difficult. When we were born, we probably had to fight to come out. We probably struggled to come out. But now, after all this work, even dying has to be a struggle, should not be that. It should be a death with dignity. And that is what palliative care also does. So this is in India, where because of pandemic, a lot of people were cremated without any spiritual or any support. And here in Nepal, where you have a bar, where your families sit there together, and with all the spiritual things, they die. So one of the most important part in palliative care is, beside the pain management, support to the family and the patient, is helping them die with dignity. Now, who should be a palliative care? Now, finally, I asked, is it a new specialty that you need a specialist for palliative care? Or should we revisit all of us specialists should revisit and become a good medical personnel? Now, tell me any new topic in palliative care that we don't learn as a good doctor or a good nurse. Any topic, spiritual support, psychological support. We are taught that we should be doing that. What we have is objectified a person into a disease, and I'm more worried about disease. When my residents take rounds, sometimes after 4 or 5 patients, I ask them, what is the first patient? They will say gastric cancer, cholangiocarcinoma. I said, is she a male or a female? Oh, sorry, is the person a male or female? They said, I don't know. They don't even know who the person is. They're so clever in the treatment of medical disease that they forget that we are dealing with a person. So who should be knowing palliative care? I think all medical persons should be doing palliative care. All of us should be doing it. Yes, we might need a few specialists when we have problem, when we have difficult cases, And it's a as you know, multi-specialty palliative care is required because there is so many things that we need to do for the patient. But I think everybody should learn palliative care and give them support. With that, thank you very much. And let the person, help a person live life for whatever time they have. Thank you very much. Any questions, I'll be glad to take.
Dr. Pradeep, Dr. Vaidya, thank you so much for sharing with us. This is a gift indeed to really be reminded of the humanity and the relationship part of delivering care to our patients and their families, and that caring is primary. And also the compelling story of necessity being the mother of invention, how you were able to deploy and pivot to bring that caring to your patients and their families. So thank you again for that. I've got a couple of questions here. Maybe
Yes.
Katie, you might want to read off what we have from Dr. Falk.
Yes, so the question from Dr. Falk is, I'm interested in his comment about the family not wanting to tell the patient that they have a terminal condition. We have frequently encountered that inclination among families in Guatemala. I would be interested in Dr. Vaidya amplifying on this topic, and also in any comments among other colleagues about this time. Does the ethics of this issue vary from country to country?
Okay, can I answer that?
Mm-hmm.
Okay, previously I have seen educated people, ministers of my previous governments, who have gone to cancer hospitals, and their son, when I go to meet the patient, the son says, "Shh, don't tell him he's got cancer." It's such a denial thing because they think he'll go into depression, he will not understand. And when we did a study, we did a small study in Hospice Nepal, and we asked them, if you had cancer, would you like to know? And 95% of people said, yes, I would like to know. But when we tell them that, would you tell the family? They said no. So we are trying to change this. And because of this problem of not telling the patient, I told you how many times we face the patient and we cannot tell them that you cannot live, it's not a disease that can be cured. But nowadays times are changing, people are more aware. They ask me, and I tell them, do you want to know? And they usually do. And I tell them, do you have cancers? And they work very happily with us for as long as they live with palliative care and all. So it is a culture. We are trying to change it. Slowly it's changing, but it still will take time. Anybody else who want to add on from different countries? Yeah.
Yeah, thank you for that. So for anyone with a question, either raise your hand, you can enter it in the chat, or just pose your question.
Yes, Dr. Good.
Yes, Pradeep, what a wonderful presentation. You know, you're a real clinician, a scientist, a spiritual man with a great rounded, and I share with Dr. Falk that we really enjoyed that talk. It was excellent. And the way you used telemedicine, you really applied it to your practice. Two questions. One is, why not using the temples and the religious leaders more? Religion is so strong in Nepal.
Yes.
And the second is home hospital concept that's growing right now, making the home the hospital with all the supports and so on. But your comments, and what a wonderful presentation.
Is there a question out there?
Two, one is, well, what about religion, bringing religion in? And the second is, what about making the home the hospital?
Okay, both are very important. Religious, yes. But ultimately, there are so many cultural and religious taboos and things, system that it's very difficult to break them. Like some group, some caste will not be wanting to die in the home. Some people want to die in the temple. So when the palliative care comes in, then we cannot tell them, wait for a patient to die there, a patient to die here, or take at home. They have to do what their society or the culture says. But having said that, we have used spiritual people. There are a lot of people who are helping us in palliative care. I think that's a very good idea, and we can use more often. As for home hospice, we have now seen that most of the people who can afford it have a ICU type of bed in their own room, and they take care of patients. And we have a lot of nursing care, caregivers, and doctors who can be called and supported. And one other problem because of that is, after the patient dies, they want to give these goods to the hospice. We have got so many donations, we have to tell them, no, thank you very much, we don't have any place to keep them. But that is a good point, and people are using more hospice service. And when previously I had to pay my cab fare for the person to go see my hospice before they would take the patient, now are referred. So people are getting more palliative care oriented. They think, oh, my relative can really get cared or helped by palliative care. So it's a good thing. Home care is, and we are doing more community service than we do, mostly community service. And only when we cannot afford to, or they cannot afford to stay at home, we bring them to our institution. Thank you.
Thank you.
And it looks like we have another question from Dr. Otto. He says that it was a wonderful, inspiring presentation. Thank you for the motivation. Who meets the cost of home visits?
Okay. Right now, we are doing it free of cost. We give the staff a motorcycle. We give him, because he could not, in rainy days, he could not reach there. We give him a van. He goes with a laptop. If patient can afford it, he's in a very good, affordable person. We charge him 1,000 rupees. That is very minimal for practically all the palliative care required. We go once a week for rounds. So all the times we go there, for all the times. If the patient is very poor, we do not charge anything at all. And all these hospice palliative care is done by donations only from our colleagues in Nepal and abroad, who gives us small donations, large donations, and that's how it works. We are all volunteers. We pay the staffs only the money, yes, amount, the salary, yes.
All right, were there any?
Just-
Oh, sorry, go ahead.
Just a comment on, again, just the amazing effectiveness of just addressing with common sense and resources that you have, and the largesse of donors, et cetera. That I think what I heard is that for 1,000 rupees or the equivalent, and a van and a motorcycle to bring people together, and of course a telemedicine platform, you can work wonders when it comes to caring for this need for so many people. Thank you again for that. Also, one other question on logistics.
Yes.
If you had on your wish list of your highest priority and for the provision of palliative and hospice care, what would be your highest priority to expand access to your served population?
I think what we missed the mark was, we thought because we were low income countries, everybody is poor. Unfortunately, that's not true. Our people are very rich. The country is poor. We built a house such that we thought we need to save money and all that. But a lot of rich people who could give money, donate money, were going to private hospitals or somewhere, and I called me, and I go there free of cost, but they're living in a 10,000 rupees room. So what we are doing is, we bought some land by donations and all. We have got 2 acres of land. We are building a state-of-art hospice where we're going to have for everybody. Rich people can stay in a very fancy place. Poor people can be served without money for all over the place. And we do training also, OPD also. So that's our goal now. Our main focus is stabilize this hospital, do the operating costs out here, and build this new hospice and provide the care that we know we can give.
Thank you for explaining that,
Yes,
and for the good news of that. That's amazing. Dr. Good.
Yes.
I just want to, his use of telemedicine, Pradeep, is amazing.
Yes.
By the way, Pradeep is with Rotary. I've dealt with him. He's been here in San Francisco training and so on.
Thank you very much.
What he's done with telemedicine, Greg and Mike, is amazing. I mean, we talk about it. He does it. In Nepal. So I want to just give you the highest accolades for your application of telemedicine to home hospital and in general teaching and the whole Nepal schema. So thank you for your contributions. You're a world leader.
Thank you very much, Dr. Good.
Okay. Well, if we have no further questions, Katie, if you'd like to go ahead and wrap this up. And for those of us who would love to have access to the recording to study and review what we just heard and to really keep the motivation going that you've shared with us. And thank you again for the gift of that, Dr. Vaidya. Just fantastic.
Thank you very much. Thank you for giving me this opportunity.
Perfect.
Okay.
Thank you everyone for joining. Really appreciate it. We'll go ahead and upload this video to YouTube once we have it compiled. So thank you again.
Thank you very much, everybody. Namaskar from Nepal. Greetings from Nepal. Have a good night or good evening. Good day. Thank you very much. See you.
Stay well.
Bye.